Professor Alistair Webb, who is a stroke neurologist working in Oxford in the UK, and he will present the guideline on pharmacological interventions for long-term secondary prevention after ischemic stroke or transient ischemic attack.
Great, thank you very much. So quick disclosures. Large group of people did this guidelines. There's lots of disclosures. They're the ones I pick out for myself, but nothing directly relevant specifically to what we're going to talk about today. This is the group of people who've done the work, who've worked very hard over the last year to put all this together. It's quite a big topic, as you can guess. I particularly like to highlight Jessie Dawson, who kind of led from the front and did a lot of the heavy lifting on this, but is presenting in a parallel session at the moment. So I'm the co-chair of the group, which is why I'm here instead. Secondary prevention is a massive topic, so I'm going to go fairly quickly through quite a few PICOs, which is hard to leave any out. But we focus specifically on the recommendations in 4 key areas applicable to all patients with ischemic stroke or TIA, largely speaking, but not including specific etiological causes such as atrial fibrillation, carotid stenosis, and so on. So it's the generic recommendations for secondary prevention of cardiovascular disease in patients who have had a TIA or ischemic stroke. So I'll go straight into it and focus on the blood pressure topic first of all. And so fairly straightforward, our first PICO question was essentially in patients with a history of ischemic stroke or TIA, does blood pressure lowering treatment compared to no blood pressure lowering treatment reduce the risk of any recurrent stroke in particular? And you may not be surprised to hear that we do indeed recommend lowering blood pressure after an ischemic cerebrovascular event. The quality of evidence is high and the strength is that it's strong for an intervention. And the reason for this is, of course, that of all the interventions we have in secondary prevention of stroke, there's quite a large number of clinical trials of blood pressure lowering versus no blood pressure lowering, demonstrating in secondary prevention there is a significant reduction in the risk of recurrent stroke, major adverse cardiovascular events, or cardiovascular death in our meta-analysis and systematic review. There's a little bit of heterogeneity between the studies, but it's predominantly dependent on PROFESS, which was the largest trial, but achieved a very small blood pressure difference. And there is a role for the difference in blood pressure you achieve between treatment arms in efficacy in preventing stroke. So a nice, solid recommendation to lower blood pressure is a good thing. And you'll see in the pattern of the recommendations, our next question we're going to talk about is how intensively should you do so? Should you target below 130/80 for a clinic reading versus a less intensive target to reduce the risk of recurrent stroke in this patient population? And again, it's an evidence-based recommendation based on trials available with moderate quality evidence. And the strength of recommendation is weak for intervention for reasons that we'll come to. So essentially, there's only 3 trials in secondary prevention randomizing to a more intensive treatment target to a less intensive treatment target, with the largest being SPS3. And across these trials, there is a significant benefit within a more intensive treatment arm compared to the less intensive treatment target. But it's only significant for any stroke, and particularly for intracerebral hemorrhage. It doesn't quite reach significance for ischemic stroke or major adverse cardiovascular events. And the other important point to note is that in the trials we have, they're quite heterogeneous in terms of that they're in specific patient populations. Most of the data is in SPS3, which is in a lacuna stroke population in particular. RESPECT included patients with hemorrhagic stroke as well as ischemic stroke. So it is difficult to say with absolute certainty that in all stroke patients that it is the best thing to lower blood pressure intensively. And there are patients in whom you may not wish to do so. For example, patients with bilateral type carotid stenosis above 70%, there's evidence from the interventional carotid endarterectomy trials that is probably not a good thing to do and to take a more relaxed target. And looking at the primary prevention literature, something like the SPRINT trial, in patients who are particularly frail, elderly, or have pre-existing renal disease, you may also not want to be too intensive. So this applies to the majority of patients. There is evidence for it, but you do need to pay attention to specific populations where the evidence doesn't exist. And then the third question effectively is linked to 2 different PICOs. How should we achieve good blood pressure control to an intensive target? And for this, there isn't as such good data in secondary prevention, so we have 2 expert consensus statements instead. Firstly, on whether to use out-of-office blood pressure monitoring, and secondly, what intervention you should use. And as you can see, we took the question, should you initiate treatment with 2 blood pressure-lowering medications compared to monotherapy to reduce the risk of recurrent stroke, rather than asking about a specific class. And the reason for that, essentially, is because, as you'll see throughout this guideline, there is an issue in secondary prevention whereby if we don't have evidence but that we should do something, If there is good evidence in primary prevention and no evidence in the secondary prevention literature to disagree with the primary prevention literature, we have resorted back to agreeing essentially with the primary prevention data for what you should do. So, for example, for out-of-office blood pressure monitoring, there are 3 small studies in secondary prevention of stroke and TIA, which demonstrate a non-significant better control of blood pressure with use of out-of-office monitoring with some heterogeneity, but it doesn't reach significance. So in the secondary prevention data, we cannot conclude definitively that out-of-office blood pressure monitoring is the right thing to do. But if you go back to the primary prevention literature, and particularly the primary prevention guidelines in Europe and America and elsewhere, then there's a strong recommendation that we should be using out-of-office blood pressure monitoring to guide effective treatment and to make diagnosis of hypertension. So we have supported that with our consensus statement and not disagreed with what we say for everybody with hypertension just because they also happen to have had a stroke. And so similarly, when it comes to what drugs you should use, the current European guidelines have moved to suggesting that you should, in the majority of patients, initiate treatment with a combination of low-dose antihypertensives rather than a single class of agents due to equivalent or better efficacy with a better side effect profile. And although we don't have direct comparison in the secondary prevention literature, the PROGRESS trial in particular, the arm which worked best was the group given perindopril plus indapamide. So there is supportive data in secondary prevention. So our recommendation is therefore to initiate treatment with a combination of antihypertensives rather than a monotherapy in most patients. And along with the primary prevention and supportive data in secondary prevention, we would suggest this should be a calcium channel blocker or thiazide-like diuretic in combination with a renin-angiotensin system inhibitor. Again, there is a small proviso that in patients who are at risk of hypotensive complications, you may want to be more gentle to the elderly, the frail, those with orthostatic hypertension or severe flow-limiting large artery disease. So, moving on from blood pressure to our next big topic, which is lipid lowering. So the same pattern of questions. So is it worth using a statin for lipid lowering therapy versus no statin to reduce the risk of recurrent stroke? Again, you won't be surprised to hear that we do indeed recommend that with a high quality of evidence, with strong evidence for the intervention. And again, this is because there are 5 studies which have reported specifically in stroke and TIA populations, ischemic stroke populations, the benefit of using a statin, particularly the SPARKLE study. And for all recurrent stroke, for ischemic stroke, and for major adverse cardiovascular events, there is a significant benefit from giving a statin compared to not giving a statin in all patients. In the 3 trials on the right, you do see there is a reliable evidence of a slight increase in the risk of hemorrhagic stroke, intracerebral hemorrhage, but this is significantly less in absolute terms than the benefit you gain from reduction in ischemic events, both for stroke and for major adverse cardiovascular events. And there isn't sufficient evidence to say if there's any specific subgroup in whom you should not do so if they present with an ischemic event. So for all patients with ischemic stroke or TIA, we do recommend a statin. Again, is it worth treating to a more intensive cholesterol treatment target compared to the less intensive target to reduce the risk of recurrent stroke? And we have made a fairly strong recommendation here, an evidence-based recommendation, that we do recommend treating to a targeted LDL-C of less than 1.8 millimoles per litre to reduce the risk of major adverse cardiovascular events in particular. But the quality of evidence for this is only moderate, despite that the strength of the recommendation, because of the amount of benefit, is strong. And in secondary prevention, this largely hinges on one trial, the Treating Stroke to Target study, which used the less than 1.8 target and was in a population with atherosclerotic cerebrovascular disease and did demonstrate a significant reduction in major adverse cardiovascular events by achieving a less than 1.8 millimole per litre target. This is supported by post hoc analyses of the other big secondary prevention studies in terms of greater benefit from achieved control down to that level. And it's also strongly supported, once again, by looking back to the primary prevention data, particularly in patients with atherosclerotic disease, that in primary prevention, more intensive control has better long-term outcomes in prevention of cardiovascular events. So we do support a more intensive treatment target. How should we achieve that? And similar to how the blood pressure was structured, So if you've given people the statin, should you add ezetimibe or a PCSK9 inhibitor? And here, the evidence is less good, specifically in the secondary prevention population. We have made an expert consensus statement that we do think you should, to achieve the intensive targets, addition of ezetimibe is a reasonable option. In the subtext, PCSK9 inhibitors can be considered, but the evidence isn't quite there yet. And essentially, there's no dedicated secondary prevention trials in the literature, and there are actually only 3 trials who report the benefits in a cerebrovascular subgroup, small subgroups of these very large trials. In particular, Improve It was a population with acute coronary presentations, and who had addition of ezetimibe. And in the cerebrovascular subgroup, there was a significant benefit from adding ezetimibe. And in TST, they largely used ezetimibe to achieve the target of less than 1.8, which is what leads us to support addition of ezetimibe as the best evidenced option in patients with stroke and TIA. The evidence from the 2 PCSK9 inhibitor trials is not significant and not yet proven as an open area of research, but in the right patients who would be eligible for those trials, they should be considered, even if they have had a stroke or not. So that's lipids. Moving on to the next very large topic is antithrombotic therapy. And the simple question to start with, in people with ischemic stroke or TIA, does long-term antiplatelet therapy compared to no antiplatelet reduce the risk of recurrent stroke? Again, you won't be surprised to hear that we have recommended an antiplatelet in ischemic cerebrovascular events. The evidence is moderate due to some heterogeneity, but it is strong for the degree of benefit. There's quite a lot of trials. They're largely old trials. They're mostly with aspirin for a single antiplatelet versus placebo. There's one salostazole, one diclopidine trial in these studies. But across these studies, there is good evidence that treatment with an antiplatelet reduces the risk of recurrent stroke, major adverse cardiovascular events, myocardial infarction, and ischemic stroke alone. There is an increased risk of major bleeding in all tissue beds. This is not significant for intracerebral hemorrhage in our meta-analysis, but the absolute risk reduction is well in favor of treatment compared to the risk of bleeding problems. Most studies are with aspirin, and so the best evidence is for aspirin as monotherapy, but the latest studies of different antiplatelet regimens against each other do support that clopidogrel is efficacious and is the valid preferred option in most places. So moving on to, should we do more than just give a single antiplatelet? Should we give dual antiplatelet for longer than 90 days with aspirin plus clopidogrel? And we recommend against use of dual antiplatelet therapy with aspirin and clopidogrel in the long term. Of note, we haven't talked about the acute dual antiplatelet therapy in this guideline. Last year, we released the expedited recommendation for that, so that's covered in a different guideline. So although the evidence here is very low, it is weak against intervention due to the potential risk of harm. Because there is a non-significant reduction in the 5 trials, quite strongly driven by ESPS2 as well, which is dipyridamole and aspirin, which may not be equivalent to the aspirin plus clopidogrel treatment regimen, for reducing the risk of recurrent stroke. But there is significant evidence of an increased risk of hemorrhagic complications, in particular ICH. So we have good evidence of harm, which is significant and proven, but the evidence of benefit is definitely uncertain. And although those NNTs suggest that there might be benefit, as I say, if you remove the dipyridamole arm, it's less convincing as well anyway. So instead of dual antiplatelets, should we use a NOAC in addition or instead of an antiplatelet in specific groups? And there's 2 questions here, which I've just lumped together for time purposes. So the first question is, should you use a low-dose NOAC, so rivaroxaban 2.5, in addition to an antiplatelet? And this derives predominantly from the COMPASS trial, which was in primary prevention, but did have some stroke patients in it, and it did include coronary disease or peripheral arterial disease as an inclusion criteria, but peripheral arterial disease included significant carotid stenosis as its definition. So it is quite a few cerebrovascular type patients, and it did demonstrate benefit. However, we don't have evidence, particularly in the patients who have suffered a stroke previously, which is obviously of issue in terms of hemorrhagic complications in our patients. So what we have concluded is where patients were eligible to be included in COMPASS, it is very reasonable, whether they've had a stroke or not, to consider low-dose NOAC plus antiplatelet for the systemic prevention of major adverse cardiovascular events. They shouldn't be excluded from that treatment regimen because they've had a stroke, because having a stroke was allowed to be in that trial. And then the final question, which I'm sure has been well worked over nowadays, is NOAC, particularly after this meeting, so NOAC versus antiplatelet in embolic stroke of undetermined source. So when we wrote this, Navigate and Respect trials were out, Atticus was presented here, and all 3 trials have not shown any significant benefit of using a novel oral anticoagulant instead of an antiplatelet in ESUS, so we do not recommend that. So, quick run through this. I know that the final topic is diabetes, and there's 2 PICOs here to finish. Again, the straightforward question first of all. In patients with diabetes who have had an ischemic stroke or TIA, does intensive control of glucose levels, HbA1c in particular, compared to less intensive control, reduce the risk of recurrent stroke? And the bottom line is there is no secondary prevention data that we could find of any use to inform about that. But in line with what I've said on the other topics, if your patient has diabetes and happens to have had a stroke, that does not preclude you from following the primary prevention guidelines for their diabetes. And so, based upon that evidence, there is benefit for microvascular complications and some evidence of benefit for macrovascular complications, although less certain. We do recommend supporting the more intensive HbA1c target of less than 53 or less than 7%, depending on which metric you use. There is some question about how aggressive and how quick you should do that, depending on how long patients have had their diabetes and what HbA1c level they start at. Because if you start very aggressively trying to get there quickly, and someone who's had an HbA1c of 13 for 5 years, you're going to make hypoglycemic complications. So there's a management issue there, but to us colleagues. So the final question, which is stroke-specific in terms of diabetes, is whether in people with ischemic stroke or TIA, does use of pioglitazone compared to no pioglitazone reduce the risk of recurrent stroke? And because there is sufficient evidence for this, that we felt able to make an evidence-based recommendation that despite its current underuse, we do recommend in patients who have insulin resistance or type 2 diabetes, pioglitazone should be used to reduce the risk of recurrent stroke. The quality is moderate, and the strength is weak for intervention because of the potential risk of harm, which we'll come to. So there are 3 trials in this area, particularly the Irish trial, but also supported by Proactive and J-Spirit, which do demonstrate quite a significant benefit from use of pioglitazone in this population, with a 30% risk of recurrent events. So there is good evidence for benefit, and there's no significant heterogeneity between the studies. The main downside, the main reasons why it hasn't had good uptake, perhaps, is the perceived risk of harm, because there was an undoubted increased risk of low-energy fracture, particularly reported in the Irish trial. So a total risk of 13.6% versus 8.8% of any fracture. There was actually only a 1.6% increased risk of serious fracture, which means that overall, although there is an increased risk of complications with use of pioglitazone, the number needed to treat for benefit in terms of stroke and MI reduction is about 36, whereas the number needed to harm for fracture, which is the most likely cause of disability in this population, is 62. So overall, the absolute benefit is in favor of pioglitazone, which led us to support use, recommending it for treatment. The other 2 groups in whom particular caution should be taken is patients with heart failure or at high risk of heart failure. But if you have had an echo and they haven't got any symptomatic history of diastolic heart failure, then that shouldn't preclude them from treatment. And there is a reported increased risk of bladder cancer, although with an absolute risk which probably doesn't undermine the recommendation. But anyone who has had bladder cancer or particular risk factors, say they report hematuria, I would not go ahead and give them pioglitazone. So quite a quick run through of a big topic. There are a lot of areas for future research, of course, in each of these areas. So in blood pressure, we don't have a good idea of the optimal drug class or combination for use in secondary prevention. And in particular, it would be good to prove that home blood pressure monitoring or ambulatory monitoring is useful. Our patients are a specific group, and many of them will not be able to do home blood pressure monitoring well enough to make it worth doing. So it's not proven that it is beneficial, but the evidence supports it from primary prevention. And we don't know if there are specific subgroups, particularly for intensive treatment, where they should not be they should be avoided. For example, intracranial atherosclerosis, who we may hear about in a minute. Lipid lowering, which drugs are beneficial after stroke? PCSK9 inhibitors, but there are other drugs, of course, coming on. I don't mention them there as well, but inclisiran and the like. and which antithrombotic strategies are preferable. As I'm sure you're aware, there are new antithrombotics coming on the market all the time, and we will hear about factor 11A and factor 12 inhibitors in the next few years, I'm sure, which may well change what we do. And diabetes, it's a very old question of whether intensive HbA1c control improves macrovascular complications, and I'm not convinced we're going to have any trials to answer that in secondary prevention of stroke in particular, but it would be good to know. But we do have questions open on which drugs are best and preferable to use. So overall, secondary prevention is good. Do it. There's a large burden of residual disease out there, and we do recommend intensive treatment, particularly of blood pressure and LDL-C, to provide benefit with whatever means are likely to achieve intensive control. At the moment, a single antiplatelet strategy in the long term is the best supported antithrombotic strategy. So thank you for your time.
Thank you. Thanks a lot for this excellent presentation and for leading this guideline. I can see that there's one question. Ready?
Yes, thank you very much. Jan from Munich. Would you recommend dual therapy in minor stroke or high-risk TIAs for 10 to 21 days, like based on chance and the point?
Yes, I didn't cover it in this guideline because we did an expedited recommendation last year, so it wasn't covered in this guideline. But yes, no, for at least 21 days, in that guideline we recommended dual antiplatelet therapy with aspirin plus clopidogrel, with consideration of aspirin. My mind's gone. Let's alternative agent from point. Particularly in the NHS 4 to 5 group. So yes, we do in the early phase. This guideline we specifically talked about after 90 days.
Okay.
And the 21 to 90 days, you can take your pick, really, depending on your interpretation of the chance data.
Thanks.
Thank you. One other question.
Thank you very much. Matilda Florentin from Greece. I would like to address 2 questions. In patients with isolated systolic hypertension, would it be a little bit less aggressive so that the diastolic hypertension does not fall substantially?
So that's it's a good question. The evidence we have is that treating isolated systolic hypertension has equivalent benefits from treating mixed hypertension. And the evidence in stroke is that there is no lower limit which has been proven that you should not go below in the evidence that we have. So the normotensive patients in progress still benefited as much as the hypertensive patients in progress. So no, at the moment we would recommend treating to target. There is a theoretical question in hypertension about, particularly in elderly frail patients with risk of cognitive impairment, is there a problem from diastolic hypotension? But all that data is observational. So at the moment, the randomized control evidence we have in our stroke populations is undoubtedly to treat to an intensive target. And there isn't even, some people even believe you should treat everybody regardless of their blood pressure. But we haven't gone as far as saying that.
And what about the SGLT2 inhibitors in patients with stroke and diabetes? Is there any evidence that they are beneficial?
Sorry, which drug did you mention?
SGLT2 inhibitors.
Sorry, I missed it again. Which inhibitor?
SGLT2 inhibitors.
Oh, yes, okay. There's no good secondary prevention data at the moment that we identified for other drugs. There is some coming out, and I'm not sure it's been formally published, but that I'm aware of. So it was one of my end conclusions. I think we do, one slight problem I have is that people at the moment slightly pick a diabetic drug believing it's going to have specific benefits and haven't tested, for example, metformin in secondary prevention populations individually. And I have a personal bias that we should know what the old drugs, how good the old drugs are in specific drug classes before we go with the expensive new proprietary drug from a drug company and say, this one's clearly better, without having tested the one that we are using in the vast majority of our diabetic patients, first of all. The honest answer is we don't know, and I think we ideally would have drug versus drug comparisons in our patients to know, and we don't have that data yet.
Thank you.
One question regarding statins.
Yep.
What is your suggestion for the patients who have already LDL cholesterol levels below 0.7, or for the patients who have a stroke of non-cardioembolic origin and without any sign of atherothrombotic disease?
Sure. So we don't specifically address it in the guidelines, so I perhaps shouldn't give my personal response to that. I think the evidence from Sparkle is that all patients were included, and that when they looked at their subtypes, they had equivalent benefit in their small vessel populations versus their atherosclerotic patients. So the guideline covers all patients regardless of those inclusion criteria, and therefore I would agree with that. And I think that there is evidence if you dig into it, but it's not mentioned in the guidelines. So I think, yes, I would treat actually all my patients presenting with an ischemic cerebrovascular event, or TIA. I would give them a statin, and if they didn't achieve 1.8, I would continue to escalate treatment to try and achieve it, is what the guideline implies.
Thank you. One other question. You suggested the use of low-dose anticoagulants plus an antiplatelet in patients who meet the COMPASS criteria. If we work in a acute stroke world,
yeah.
when it's the optimal time to start this treatment?
So again, we don't cover it in the guidelines specifically, and of course we have no evidence. The COMPASS data was all in patients in the chronic phase. So I think in the chronic phase is the right answer. So I think after we think there's any significant risk of that we're going to increase the risk of hemorrhagic conversion. So I personally would wait for at least 2 weeks for that particular treatment option because of the lack of evidence in secondary prevention, and possibly longer. In reality, we'd be introducing it at their follow-up clinic, I think, in our clinics, which would be a few weeks down the line.
Thanks. There are other questions, but for the sake of time, we have to move to the next guideline.
Thank you
Thanks very much.